talk about anxiety disorders for behavioral science and psychiatry for Falcon Physician Reviews. Anxiety disorders are much more than just simple nervousness about common things. They have both an aspect of psychological and physiological components. Symptoms can dramatically impair patients from accomplishing the simplest task, and patients with anxiety feel a sense of impending doom that is not realistic and are well-defined. So there are two different kinds of symptoms. There can be a psychological symptom and a physiological symptom. Psychologically, there's excess worry, hypervigilance, problems concentrating, restlessness, problems with sleep. Physiologically, they can get lightheaded, tachycardic, their blood pressure can get up, they can start sweating, nausea, vomiting, fainting, muscle tension. There are several anxiety disorders that we're going to cover here, including panic disorder, phobic disorders, obsessive-compulsive disorder, post-traumatic stress disorder, generalized anxiety disorder, anxiety associated with a general medical condition, and substance-related anxiety. So the first disorder we're going to talk about is panic disorder. And this is an anxiety disorder which is characterized by recurrent and unexpected panic attacks. And in addition to having the attacks, they must also have a month of a concern about future attacks. So they're constantly worried they're going to have another attack. They have to worry that they are going crazy or that they're going to die. And it has to cause a significant change in their behavior related to the attacks. Generally, these attacks also should come out of the blue. Shouldn't be precipitated by something. In some cases they are, but most cases of panic disorder, the attacks will just come out of the blue. As with all psychiatric disorders, these symptoms must not be due to substances or a general medical condition. Panic disorder affects about 2% of the population, and most commonly in females, and usually they present in about their 20s. Agoraphobia is a little bit more common. It's at about 2 or 6% of the population. Again, more common in women, and may occur with or without concurrent panic disorder. And what agoraphobia is they're fearful of being in open spaces. And they're fearful of open spaces because they fear that they can't get out. What is the differential of panic disorder? You should differentiate it from any other kind of medical illnesses, such as thyroid problems. If you have diabetes, are you having a hypoglycemic episode? Are you using any other drugs or substances such as cocaine, amphetamines? Make sure that those are not the causes of your panic disorder. Also want to make sure that it's not due to some other kind of mental illness such as psychosis or obsessive-compulsive disorder. Panic disorder may be present with agoraphobia, or it may present without it. And when you code for it and when you diagnose it, you just have to add panic disorder with agoraphobia or panic disorder without agoraphobia. So what is the characteristic of a panic attack? Generally, the patient will tell you that a panic attack will peak within minutes, and usually about 10 minutes, and along with which they will have at least 4 of these symptoms: palpitations, sweating, trembling or shaking, shortness of breath, choking, chest pain, nausea, feeling like they're losing control, chills or hot flashes, fear of dying. Now, I don't expect you to memorize this entire list, but if you were to go from head to toe of all of your systems autonomically, you could easily remember a majority of these symptoms. So you could think of feeling lightheaded, blurry vision, sweating, your heart beating fast, you can't breathe, nausea, vomiting, going down to your legs, feeling like you're going to fall over, feelings of depersonalization, derealization. So this is not something that I would say that you would have to memorize. I think that you can use your common sense and think of the symptoms. Remember, though, you must have at least 4 of these symptoms in order for it to be a panic attack. So how do you manage this anxiety disorder? Well, cognitive behavioral therapy is very, very helpful for panic disorder, especially with or without medication. There is no evidence to suggest which one is better. And pharmacotherapy can be based upon side effects, profile of the drug, cost of the drug, as well as if there is any history of any substance abuse, because with these patients you'll be very careful if you want to give them a benzodiazepine. You can treat them with an SSRI. They're more expensive and they take longer to work, but they're good in the long run because they will prevent the attacks from happening once the medication gets in your system. Benzodiazepines are most used because they are very rapid and they will immediately treat the panic attack. But the problem with this is that they can be addictive and there can be abuse potential. So if you have a patient that has an occasional panic attack, maybe once a month, twice a month, a benzodiazepine would be okay. And especially if you know the patient doesn't have a history of drug abuse. But if this patient has multiple panic attacks, has a history of drug abuse, then an SSRI would be the way to go. You can also try a tricyclic antidepressant or an MAOI, but these would be second and third line therapies if the other two types of medications didn't help. Agoraphobia is best treated with exposure therapy, where the patient is slowly and repeatedly exposed to the environment that they're afraid of, and eventually they will overcome the anxiety with the help of a therapist. Next we'll come to phobic disorders, which are the most common types of psychiatric illnesses in our population. And it's an anxiety where the patients have an intense fear over specific situations or things, and this is what's called a specific phobia. And it's an irrational fear. Now, social phobia is different from a specific phobia, as people are very fearful of a public or social setting, and the main important feature of social phobia is the fear of humiliation or embarrassment. So that must be present for you to have social phobia, is the fear of humiliation or embarrassment. And it can occur in many situations or a certain situation that doesn't have to be specific, but the humiliation or embarrassment is the most specific. And exposure to the specific source of anxiety must elicit the anxiety reaction, and fear and avoidance of the feared source should cause functional impairment. Again, specific phobias are the most common psychiatric disorder, about a lifetime prevalence of about 25%, women more than men, and generally occurs in childhood. It starts in childhood, most often before the age of 25. Differential diagnosis of phobic disorders, you want to rule out other mental disorders of anxiety, such as school anxiety or separation anxiety. Want to rule out any medical causes, any substance-related causes. And the management of phobic disorders will usually be cognitive behavioral therapy. If it's very, very severe, then you can use serotonin reuptake inhibitors or benzodiazepines, Buspar, or MAOIs. Obsessive-compulsive disorder. So obsessive-compulsive disorder is the presence of intrusive thoughts. So these are obsessive thoughts that the patient cannot get out of their head. And in order to relieve this anxiety, they have peculiar behaviors or compulsions to relieve the anxiety is obsessive-compulsive disorder. And frequent obsessions include fears of contamination, being unsafe, aggression, sin, crime. And common compulsions include checking, locking, hand washing, counting in their head, praying. And the reason why this becomes a problem is because the worrying about the obsessions and carrying out the compulsions takes up a lot of time and causes significant distress. Also, a patient with obsessive-compulsive disorder will say, "Doc, I know what I'm doing is crazy. I know that these thoughts are just not making sense. I don't know why I have to do them, but I just can't stop doing them." So that's a very important point about obsessive-compulsive disorder. Again, you want to rule this out with someone who's psychotic, because a person with psychotic will be dead sure that whatever they're doing is because their hands are really dirty or because the doorknob is really dirty and they will get an illness. They won't be able to say, "Hey doc, I know what I'm seeing is not true, but I can't get it out of my head." They'll say, "No, this is really true. It's a delusion, so it'll be a fixed false belief." So with a person with obsessive-compulsive disorder, look for someone in their late teens or their early 20s who have waxing and waning symptoms of obsessive and intrusive thoughts. They are associated with compulsive activities. And also remember that depression and substance abuse are frequent comorbidities with obsessive-compulsive disorder. Clomipramine, which is a tricyclic antidepressant, has the most serotonergic activity out of the tricyclic antidepressants. That can be helpful, as well as the serotonin reuptake inhibitors, in particular fluvoxamine. Exposure and response prevention is also very helpful. And other behavioral therapies that are helpful are relaxation training, systematic desensitization, and modeling. Now we'll take a break for anxiety disorders, for behavioral science and psychiatry, for Falcon Physician Reviews. Now we'll take a break for anxiety disorders, for behavioral science and psychiatry, for Falcon